Thank you all very much collectively for inviting me to give a talk on probably a topic that doesn't often get highlighted in a general session about hospital control of infection. I started preparing for this talk by looking for a really nice sort of cover image. I found this on the web. I really like it, the sort of knockout punch of the microbes fighting back as a kind of metaphor for antimicrobial resistance. And I thought when I looked at it carefully, this is perfect for me because there was absolutely nothing on that slide that I was going to talk about. But that was the problem, and the first problem I wanted to tell you about. You see, on that slide, if you look carefully, there's lots of different viruses and there's bacteria, and I think there's a blue nematode worm there. But there's not any fungi at all. And that might be because in the past people have thought it's not a big problem, it's not a big deal, don't see very much of that. And I think that kind of view prevails to this day in many communities. So the first thing I want to do is to get rid of that view. So I'm going to start with an equation, or a sum, really, and remind you all that, of course, if you're talking to your family about infections, they'll know about certain household name infections. So, for example, they'll know about things like malaria, they'll have heard of tuberculosis, they've heard of HIV, etc. They probably couldn't name a single fungus, though. Here's the equation. So here's the numbers which add up to about 3 million, and those numbers which are taken from these sources, I don't know if you can see at the bottom, but they're all published sources, equate to this. They're the sum of all those deaths due to HIV plus the sum of all the deaths due to TB and malaria. Then you add another 1.2 million people, and that gives you the number of annual deaths a year due to fungal infection. And that is served by a community of researchers which typically represent about 3% of the infectious disease community. It's not that it's not important, it's sort of come up on us very quickly. I'm going to benchmark it a different way because other people deal with other types of disease. So let's look at human cancers. Series of numbers, and they represent this. The numbers of deaths globally due to breast cancer, to prostate cancer, to bowel cancer, plus 1.7 million is the number of fungal deaths. And if you want to, you could add the most common form of cancer, which is lung cancer, and that's just about equal to that last number. So all of those cancers together represents the global burden of fungal deaths. It's a massively important problem. Now, putting this in a different way, it's not just deaths, but the burden of infections and disease in humans is actually very profound. WHO lists the most common human infection of all are skin infections, and most of those are quite benign, but actually all of us have got dandruff, that's a fungus for a start, and most of us are colonized by other fungi on our skin. That actually is a massive industry. There's a lot of money behind that, but actually to cause relatively few deaths, it does cause a lot of morbidity. For women, that second number at the top, 150 million, is the number of women who get at least 4 episodes of vaginitis a year due to Candida, which is a miserable sentence. And allergies, we think about allergies due to dander and pollen, but actually hypersensitization to fungal spores are really very important. And this doesn't even include recent studies on COPD, which probably represents about 6% of all of those cases, 500 million people per year. So daily risks, about 13 million people. I think I'm really hammering this home now, but this is the point, that this is a very, very significant clinical problem which we need to be aware of and do something about. And it's getting worse and it's changing dramatically. And those numbers would be much, much different if this presentation was 20 years ago. So luckily, this has not gone unnoticed by significant organizations like WHO, who've had a number of publications about diagnostics are very important because for these sorts of diseases, the life-threatening ones, late diagnosis always equates to poor prognosis. They, very importantly, in 2022, published their priority list of pathogens for fungi, and recently they've also done a survey of antimicrobial agents, which I'll talk about in a minute. I'd hoped that this would just coincide with their latest publication, but it's due in a few weeks' time, still hasn't come out. And it's this publication which is all about, in the bottom of the slide, actionable interventions around the world. So advice which are things which can be done straightforwardly, easily, and some which are, they call them the high, moderate, and low feasibility. So things which we could do straight away to make a better world, and those things which would take more work and more planning and more investment. But they're to do with improvements in public health, they're to do with advancement of therapies, that are to do with laboratory systems, surveillance, and also social and economic drivers of disease. And I want to touch on some of these problems in a second. Very recently, and actually Ed was involved in this as well, because the first author, which you won't be able to see, top left of that publication, which just come out in Nature Medicine, is Paul Verwey, who's one of Ed's colleagues and was involved in the study. A lot of people are getting behind this, and these publications are at least making this problem much more aware. And awareness is an incredibly important part of the pathway to doing something about this. I want to talk to you about a few things, little vignettes about this story. I want to mention some of the things which are challenging us and perhaps are explaining why things are coming to the fore quite quickly. Climate change, for example, is one that we're worried about. The emergence of new drug-resistant strains and species, drug resistance in general, and rapidly changing socioeconomic factors I'll touch on only very briefly. But the climate change thing is an interesting one. It's not absolutely clear how climate change intervenes directly, but it certainly has a number of indirect causes. So in this panel that you can see at the top, climate change brings with this various other types of trauma. For example, severe storms, drought, and flooding. Amongst those, there are people who get badly injured, and many of those are colonized by fungi, and they can have diseases which are affected by that. Climate change is changing the host range in which you see diseases around the world. And fungi generate spores, and spores are very transmissible in air currents, and so you get rapid spread of fungi with different properties. And we see that dispersal into communities very quickly. And these things are cross-reacting with other things which we think of outside of the hospital, other ecosystems, agriculture, in wildlife, but also affecting human disease. Let me explain a little bit about that. So there are many sources of antifungals which can be drivers to generate resistant strains. They exist and are used in all sorts of different ways. They're used clinically, obviously, but they're used as anti-fouling agents. They're used in agriculture a lot, which is a very important element of this. And they can then, that's the green circles, and then the orange circles are where there can be selected, where the selection for AMR can take place, and there's a wide range of them. It's not just in the hospital, but also in soils and in foods and in plants, and they can be transferred through a variety of mechanisms to encounter us and to make a big difference. These are just some of the organisms. I want to just touch on one or two of them which are important. And I was glad to see, actually, that a couple of these have been picked up in talks earlier on today. I'm going to tell you a little about Candida auris, which we're now very concerned about, and it's the first reportable fungal disease in the UK. But other organisms are becoming important, which we haven't seen in this context before. Drug-resistant Candida parapsilosis is emerging in continental Europe. The air that we breathe is now loaded with azole-resistant spores of aspergillus, 5% in the UK, but bad news in the Netherlands, it's more like 10%. Emergomyces africanus is a new organism in Africa, and I'm going to tell you a little bit about two different skin-infecting organisms, which if you haven't heard of now, you probably will, unfortunately. But let me start a little bit with Candida auris. So it's been in the news and been suggested that this might be the first example of an organism which is the consequence of climate change. The reason for that is we never heard of this organism even about 10, 15 years ago. It didn't exist. It wasn't in any culture collections. There had never been an infection. And now it's suddenly emerged around the world in many different places. Let me show you a little bit more detail. So there are now 6 different clades of this organism, which is a multi-drug resistant, can be multi-drug resistant. Many of them are fluconazole resistant. Many strains have got resistance to more than one antifungal drug. And all of these clades could be thought of as species. They're not related to one another. They haven't spread from a single site. These organisms have evolved independently in different parts of the world at the same time. So why is that the case? We don't know. But one suggestion is because this organism has been an environmental organism, but during times of very hot weather in the summer, it's not the 2 degrees that's changing year on year, but it's the hot weather in the summer is training organisms to become able to grow at 37 degrees and then enter into the human ecology. This is a suggestion. Anyway, it's also a difficult organism in hospitals because it's very difficult to eradicate, hangs around on surfaces for long periods of time. It's very stress resistant, and we worry about it. Actually, we deal very well with it in hospital settings in the UK, but in places like South Africa, it's now replacing some of the common candidas as one of the primary causes of candidemia in hospital settings. And it's not alone. There are others out there which are much less well known. Here's another couple of organisms, Tardiomyces species, which are also organisms which seem to have made this host jump. They've become temperature adapted. They've entered into sort of human environments and are stably now associated with them, and they have reduced susceptibility to drugs, just what we don't want. And this is undermined by sort of basic studies in the lab, which show that when you temperature adapt a fungus, you not only perhaps generate the capacity to grow on us, but other things unfortunately come with it. So this study suggests that this organism in this lab conditions, which became temperature adapted in the lab, also increased its virulence and reduced its susceptibility to the first-line antifungals which are used to treat fungal infections like fluconazole, caspofungin, and amphotericin B. All things which are coming with this temperature adaptation. Now this is rather a beautiful picture. It's actually the bottom of a multi-teter plate, and these are fungal microcolonies, filamentous molds. And this is a fungus up there, Trichophyton indotinea. And I want to tell you a little bit about this because this is something which is affecting the UK very much now. This causes this really aggressive, highly inflammatory skin infections that you can see from these clinical pictures. And it's, again, an organism which did not exist clinically in 2017. The first case in the UK was about then. And this is a study from a group of collaborators. Andrew Boorman is the head of the Mycological Reference Laboratory, which is based in Bristol. And Andy's seen the first cases of this organism in 2018. It's the dark blue bars at the top. And that's data up to 2024. He tells me in 2025, 40% at least of all clinical referrals are of this organism. And they're all resistant to the first-line agent that a clinician would give to treat a fungal infection, which is terbinafine. They're either clinically resistant or they've got the mutation which makes them genetically resistant as well. And this is a very difficult situation because it's spreading very widely. Initially it was focused in and around London, but now we're seeing it across the whole country, and we've seen it in many other countries as well. And indeed, it's now more than 36 countries have reported in the last few years. More than 50 of those cases are imported infections, which are then spreading from the source of importation. So this is becoming very quickly an endemic organism, a drug-resistant organism, and we're actually short of methodologies to deal with that fungus. And it's not the only one. Again, this is another group quite closely related, very closely related genetically, but the very first case of this organism, which is Trichophantid indotineae, is type 8 of the Mentorgophytes group. This is type 7. We didn't see any of this until first cases were last year, but it looks like this is the beginning of another slow fungal pandemic. Okay, so that's the first thing I wanted to get over. The fungi cause a serious degree of clinical burden. We're seeing the rise of drug-resistant organisms. We need to be able to do about this. We need to understand it, support it, research it, and prepare for it. And we need to do it quite quickly because, you know, there's this so-called the preparedness paradox, which means that if you prepare early, you're often accused of exaggerating the problem because it doesn't emerge. But if you don't know about it, then you're accused of not doing anything about it, which is a real problem. We're at that stage where we potentially could do something about some of these because they're brand new into the UK. But there isn't very much time. And what can we do about it? Well, we need, obviously, first-line drugs. So for us, those of us who work in this field, we don't have, you don't need to read this, obviously. This is just a list of antibacterials. Wouldn't it be great if we had that? The list for antifungals is about the same size as the list that Ed was telling you was available for C. diff, for all of the fungi, which is really unfortunate. And the different colors means the different targets, which just means that actually there's precious few targets. The drugs that we do have fall into a number of clusters, and most of them are quite old. They came out in the sort of between 60s and 2000s. There are a few new kids on the block which are going through clinical trials, phase 2 and phase 3, of which the top two on this graph, fosmanogepix and chlorophyll, are not yet clinically available broadly, but they're good against drug-resistant organisms, and so that is great news. The more sobering news is these drugs, or at least orthologs of them, chemically similar drugs, the same basic structures, are also being trialed in the environment as fungicides at the same time. So we've been waiting for these buses to arrive for a long time, new antifungals, new classes, but they're being used in crop protection scenarios. And there's a real worry, which we need surveillance to make sure this doesn't happen, that they might also generate and drive resistance, which will enter again into the clinic like we've already been seeing with aspergillus and azole resistance. I won't tell you about resistance. There's one bit of good news and quite a few bits of bad news. But in terms of the good news is fungi don't have plasmids, so they don't inherit drug resistance at once as a group. Never say never, but at the moment we don't know of any examples of that. The bad news is they're very slippery and very adept at becoming resistant very quickly. They can survive in a kind of small population, which you can't eradicate very easily. They've got tricks that they play with their chromosomes. They can multiply genes which are important for them for drug-resistant properties like drug efflux pumps and get them out, get rid of them. There's all sorts of ways they can very rapidly become resistant. And I was going to just show you one piece of work from my own lab, and maybe you could just click these. What you're seeing here is aspergillus on the right, and on the left, Candida albicans. And these have been exposed to a drug called caspofungin, which damages the cell wall. It's a sort of penicillin against a fungus. And you can see very quickly these bright blue sections of these cells. And these are cells reinforcing their wall because fungi have got like two peptidoglycans. You damage one, it builds the other one, and it does it very quickly. You can get 7 doubling dilutions less sensitivity in 2 hours. It's not even a mutation, it's an adaptation. And there's aspergillus on the right-hand side forming these very unusual-looking colonies which can survive drug treatment very adeptly. So they're very rapidly adapting as well as resistant. There is some good news, though, and I just want to end with a few bits of good news. So, for example, the first, actually the second, but one of the very early fungals generated in the, way down in the 1950s, amphotericin B. It's a drug which is a broad-spectrum antifungal, which are as rare as hen's teeth. So we've had to use it to treat fungal infections for a long time, but it damages the kidney. But recently, brilliant work by a chemist in the US has worked on this and reduced, chemically modified it, which is in D, by making very carefully changes to the chemical structure, which massively reduces its nephrotoxicity. And this work by Martin Burke has really created a drug out of an old drug, which makes it very much more palatable. And so there's great optimism that we'll be able to repurpose old drugs. This is a drug which wasn't designed as an antifungal at all. It's called miltefosine. It was designed as an agent against leishmania, which is a parasite. But it's got very broad antifungal effectiveness, and we've been studying this at Exeter as a possible way of increasing the armamentarium against fungi. There are no vaccines against fungi, and there are no biologics against fungi, but antibodies do work, and the future may also help treating fungal infections with antibodies. So these antibodies were made by a PhD, then postdoc of mine, who started this company, which is behind the chairs here, Mycology, which span out earlier this year. And these are antibodies which strongly opsonize the fungus, and the green blobs, if you can see at the front, are being very rapidly hoovered up by these macrophages. And this demonstrates antifungal activity in animal models and could be work alongside antifungal drugs to give us an extra boost to things that we can do against fungi. And of course, antibodies are very safe molecules because they're natural molecules, and they have their place alongside antifungal drugs. And this is a piece of work I'm doing with the top person there, Miraz Zaman, who's a chemist based at King's College London, and he's learnt how to make drugs which are effective but can be pushed out of the cell, efflux very quickly. He can make them retain their activity as an antifungal but reduce their ability to be spat out again by drug efflux pumps. And these can generate drugs which are over 100 times more efficacious than the primary drug. So another optimistic vision for the future. And the last thing I want to say is, in the past, we've really been looking at drugs one by one. And one of the futures we're beginning to explore at Exeter, my colleague and myself, Elaine Bignell, are looking at using various commercially available drugs in combination. And there are some very exciting combinations which have existed for antibacterial chemotherapy for some time, which seem to work very well, and again, gives us options for treating drug-resistant organisms. All right, so I listed all the points I've had, but really they're all present in this summary slide here, which is that picture needs to be modified. We need to think about the fungi alongside the viruses, the bacteria, and other microbes which cause infections. And if we don't do that, and we don't catch these early, we're going to be in a difficult position in our hospitals. All right, so I have the pleasure of working in Exeter in the MRC Centre, which has been set up to study medically relevant diseases caused by fungi. I've got some fantastic people that work with me. We work internationally. We have hubs which are based in Sao Paulo, in Cape Town, and a new one which will open up in Bangkok this year, which enable us to generate international networks of people working together to work on this set of problems. And here is us on our retreat recently, probably causing the greensmen no end of anger, because we're standing on the green, I see. Right beside their tail, we have our annual retreat. We're very proud to see it's a very international group, and we're dedicated completely to making a difference in this sphere. Thank you very much for your attention.